Good morning and welcome to Cardiology Grand Rounds. It is my great pleasure to introduce Dr. Alina Manami to give today's talk. I think a lot of you know Alina as an amazing heart failure clinician, but you don't know about Alina. Alina was born in Tokyo, Japan, moved to the United States at age of 9 to Southern California, went to UCLA undergrad, then had a brief stint on the East Coast at George Washington University for medical school, came back to the West Coast for residency and chief residency at OHSU, and then came here for cardiology fellowship, where she has stayed on as faculty. What you don't know about Alina is that she is an amazing cardiac physiologist. She was actually instrumental in setting up Chuck Murray's cardiac physiology lab back in the day. She was the first person who was able to do myocardial infarctions on little tiny mice. And I remember a patient in the cath lab for a biopsy talking about how she was his favorite person to do her biopsies, because if she could do catheterizations on mice, he had no qualms about her sticking catheters in him. So Alina's going to talk today about one of the scourges of our field, and I'm really interested to hear the updates on this and if there's any hope for our patients. Coronary allograft vasculopathy, is it an unbeatable foe, Alina?
Thank you very much, April, for the wonderful, generous introduction. So this morning, I'm going to just go ahead and sit up here. So this morning, for the next 4 or 5 minutes or so, I would like to speak to you about coronary allograft vasculopathy, which, I find is one of the bigger challenges next to antibody-mediated rejection in managing our post-transplant patients. There's still clearly not much of progress and understanding on how to prevent it and slow down the process once it's diagnosed. There has not been any impactful changes over the past 25, 30 years in the area. I think predominantly because there's lacking of animal models that truly mimic the human immune system, and study results are really based on small cohort studies and institutional practices. So I'd like to start the talk with 2 cases. They're both my patients. And the first is a 38-year-old female who was transplanted on December 14, 2018 for postpartum cardiomyopathy. And she was already highly sensitized going into transplant with robust class 1 and class 2 antibodies, which makes her prone to early rejection after transplant. And as such, 2 weeks into transplant, she developed antibody-mediated rejection, which required treatment with plasmapheresis, which removes the antibodies, and IVIG and rituximab, which blunts and suppresses the antibody and also tries to decrease further antibody production. Unfortunately, due to some compliance issues, she had low immunosuppression levels, which caused her to have grade 3 rejection in July of 2019. And as already shown here, this is her first year angiogram, which already shows these significant changes that we see, where she has diffuse disease along the LAD. She has a tight proximal lesion already. The circumflex is already diffusely diseased. And of to note is that she has distal tapering, all consistent with accelerated coronary allograft vasculopathy. The second case is a 25-year-old male with presumed myocarditis transplanted on September 9, 2019. And unlike my first patient, he is not sensitized going into transplant, and he has not had significant rejection so far. And the ongoing issues with him include hypertension, obesity. He gained a lot of weight on prednisone, and then diabetes. And his first year angiogram shows the following. The epicardial vessels, unlike the first one, is fairly plump and robust. This angiogram was reported as normal, but it's hard to know whether there's some activity already gone in the distal bed. So today I will discuss the differences of transplant vasculopathy from atherosclerosis and review the methods for diagnosis and some limitations, followed by current management and prevention strategies, and hopefully end with the discussion of potential interventions and future projects centered on the topic. So why is CAV an issue in transplantation? So despite improvement in immunosuppression, the graft median survival remains about 13 years. And already by the third year, 30% of patients develop angiographic evidence of CAV. And by the 10th year, over half of our patients have CAV. Coronary allograft vasculopathy also causes about 10 to 15% of graft dysfunction and mortality in the first 3 years. And the only viable treatment option is retransplant. But unfortunately, the outcomes are not robust as the initial transplant. So therefore, we have to kind of figure out ways to develop and slow down the progression of CAV, and so that we can extend the viability of the initial transplant and improve outcomes. So when we compare CAV to atherosclerotic vessels, atherosclerotic vessels tend to be focal and eccentric, as shown here, predominantly comprised of fibrofatty plaque with a cap and variable lumen diameter, as we see in angiography. But CAV lesions, as many of us know, really are different in that it really is extensive involvement in the vessel. And both the intima, media, and adventitia are all involved. And eventually, with this active process, smooth muscle cell proliferation continues to be robust, causing near obliteration and complete obliteration, as shown here in this slide. Furthermore, once CAV is diagnosed, it is a rapid progress, as shown here, compared to the conventional atherosclerosis, which takes decades to develop. The rate of progression of CAV can vary from slow to accelerated, but as you can see, it's a fairly rapid process with really a short lifespan, unlike our atherosclerosis, predominantly because of the accelerated development which occurs. So unfortunately, despite over 30 years of transplantation, the exact pathogenesis of CAV is not yet defined, but it is believed to be an interplay between immunologic and non-immunologic factors that are triggered with injury or inflammation. Endothelial injury is the pinnacle of initiating the process. And it's due to the fact that endothelium is laden with MHC class 1, class 2 antigens along the surface. And when injury occurs, which can be from ischemia reperfusion or antibody binding to the MHC causing rejection, recipient antigen presenting cells, dendritic cells, start to stimulate cytokines, which further activate T cells. And the activated T cells continue to recruit more inflammatory cells to the area. And this triggers production of smooth muscle cells to offset the strain of the vessel and eventually causes intimal narrowing. Obviously, this is very basic in terms of what I've explained, but there's so much more that I don't have time to go over, and I don't have the expertise to really go into the detail of that. So what are some of the causes of CAV? So as mentioned, it's split into immunologic and non-immunologic. And the immunologic causes are really rejection, HLA antibodies that directly affect the endothelium, as well as non-HLA antibodies. And then the non-immunologic contributors, such as organ preservation injury, ischemia reperfusion injury in the donor, as well as everything else is listed here. And this is just some highlights. We still don't have all of the extensive causes, as I mentioned. So really one of the triggers of CAV development is endothelial injury. And in our population, it really is antibody-mediated rejection. And antibody-mediated rejection is the hallmark of the injury process. And as antibodies against HLA antigens bind to the surface of the endothelium. They triggered complement and secrete cytokines such as interleukin-2, interleukin-6, further recruiting inflammatory cells as mentioned. And that can activate complement, which further causes localized cellular destruction. And eventually the vessel is injured and over time forms CAV. Once the presence of DSAs that are specific to donors, antigens are present in the system, it is challenging to clear them and likely reflects a marker of ongoing inflammation, stimulation, progression of CAV. The severity of injury is graded here in the grading system from PMR 0 to PMR 3. And the grade is dependent on the burden of inflammatory cells. And the PMR 1 is differentiated between the presence of endothelial swelling, which is the histologic feature, and then the presence of complement staining, which is measuring C4D, which is the breakdown of complement products, as shown here, and then on this histogram. So the definition of antibody-mediated rejection, which is really an involvement of complement activation and also the changes histologically. In addition to antibody-mediated rejection and active graft dysfunction, there's presence of donor-specific antibodies that's not in the setting of acute rejection or graft dysfunction that can also contribute to CAV development and eventual graft dysfunction. There's two types of antibodies that's formed, class 1 and class 2s, from the major histocompatibility profile. And class 2 in particular has a 4-fold increase contributing to future antibody-mediated rejection. In the small Mayo study using 3D IVUS, there's progression of CAV based on changes in the plaque index over 3 years. And this was not seen with the class 1s, although the number of patients in the study was very small. I personally think the presence of these antibodies is a sign of ongoing immune stimulation with some unidentifiable antigen that's producing the class 1 and class 2 antibodies and continue to form vessel inflammation, which continues to contribute to smooth muscle cell proliferation. In addition to the antibody-mediated rejection, high-grade cellular rejection can also cause changes. In high-grade cellular rejection, there's destruction of cardiomyocytes and vessel inflammation, which on this OCT study shows that all vessels, including the proximal distal bed, can be involved. The OCT showed, as I point out here, some thickening along the vessels here. So really the bottom line is that once patients have an episode of antibody-mediated rejection or significant cellular rejection, we can expect to see coronary vessel changes and eventually long-term impact on graft function due to the development of CAV. So how do we diagnose CAV? So ISHLT developed a CAV nomenclature primarily for consistency in classification, mostly for research purposes. But as you can see, there's 4 types of classification, with CAV3 being severe, which involves all of the features here. And there's different lesion types that are standard for atherosclerotic vessels that's also used for CAV. The type A lesions show the discrete tubular branches with multiple stenosis. And then the type C lesions have a more narrowed, irregular shape with basically terminations at the tip that are non-tapered and squared off, ending abruptly. The type A and C lesions are the most frequent in CAV lesions. This is a busy slide, but just wanted to point out some of the details in terms of the changes that we see in CAV. And many of the angiographic and vascular characteristics of CAVs was performed in the late 1980s at Stanford. To be honest, I'm so impressed at how much time these investigators spent reviewing all of the angiographic data to characterize these lesions. I can expect that they spend hours reviewing each angiogram. So this work showed the distribution of CAV vessels in transplant patients, comparing them to the non-transplant coronary artery disease vessels. CAV vessels, as shown here, affect multiple layers. The primary vessels are the epicardial, the secondary vessels are the branches, and then the tertiary vessels are the distal small vessels. As you can see in coronary allograft vasculopathy, you see involvement of the primary epicardial vessels and mostly also the tertiary vessels, whereas in patients with coronary artery disease, the proximal vessels is mostly involved, with minimal to no tertiary vessel involvement in this particular study. I'm not sure why the distribution is seen, but in our patients, we clearly see this angiographically as well. And perhaps the smaller vessels with distal tapering have more strain due to the small lumen diameter, which with ongoing inflammation, as I pointed out, causes more rapid smooth muscle cell proliferation of obliteration. So it could be basically a vessel lumen phenomenon. And in patients, in addition, patients with transplant vasculopathy have minimal to no collateral circulation, unlike the conventional coronary artery disease patients, where collateral supply is robust, as shown here. So eventually, these changes, contribute to graft dysfunction from ongoing ischemia. So investigators at Stanford further carried out and determined that IVUS is really necessary to really improve sensitivity in the detection of early CAV. And as shown here, this angiogram appears to be normal, but with IVUS, you clearly see the intimal thickness that is characteristic of CAV. And they developed the IVUS classification mostly for consistency and quantification of the severity of CAV from minimal to severe. And then depending on the thickness, you can determine this whether or not the CAV is significant. As shown on this slide, which looked at normal coronary angiograms, you could already see that with angiographic evidence of normal angiograms or angiography, with IVUS, you can really see that these angiograms are indeed not normal and that the patients already have pretty extensive CAV development. But what is usable with angiography is that if you can see abnormal coronary angiogram, it really does correlate with severe CAV, as noted here in IVUS. There is also donor contribution to vessel morphology, but based on the earlier studies, Stanford, donor presence of coronary disease appeared to not contribute to accelerated coronary allograft vasculopathy. So why do we care about early detection? Well, early detection of CAV is useful for prognosis. And in this multi-center study, IVUS was performed 4 to 6 weeks after transplantation, and again 1 year to look for changes in the intimal thickness over time. In the first year, IVUS results did, according to this, does predict long-term outcomes and validated in other studies. There's strikingly 3.5-fold higher death and graft loss in 5 years in the rapidly progressive group, with 4% of the deaths in this study were due to sudden death. And there were also more luminal irregularities in the rapidly progressive group. More recent studies show that IVUS in the LID with intimal thickness greater than 0.5 millimeters can predict outcome without needing to measure the change in the intimal thickness as in the other studies, so that we could use IVUS data in real time to confirm and also to mark whether this graft has higher risk for graft dysfunction and CAV progression. So once moderate to severe CAV develops, outcomes are poor, as shown in this slide. If you develop moderate to severe CAV, essentially the risk for mortality is high, with 50% risk after 5 years of diagnosis. And then once intervention is performed, the mortality and graft death is even higher. So this study looked at the impact of revascularization long-term outcome, and then patients who were able to undergo stents had significantly improved outcomes compared to CAV lesions that were not stented. And the vessels that could not be stented may represent higher burden of disease. It usually is due to very diffuse disease that likely impacts blood flow and develop further global ischemia. But despite the interventions that we see here, the mortality or risk of mortality after a PCI is pretty high, with an average of 4 years after an intervention. And once an intervention occurs, patients have to undergo repeated interventions due to high risk of instant restenosis in these vessels, likely due to the fact that there is endothelial dysfunction and accelerated progression of the disease distal to the stent that was shown in other studies. Therefore, really early detection and prevention of CAV to this stage really does impact outcome, and perhaps that's really what we have to target. So there are many people or patients who are unable to undergo angiography at year 1 due to renal insufficiency. And a lot of the non-invasive testing that is performed really doesn't allow us to predict early CAV, as shown here. So we perform a lot of non-invasive modalities, such as the butamine echo and SPECT scan. But until the CAV lesions are severe, the predictive value is fairly poor. So cardiac PET has the advantage of measuring coronary blood flow reserve and potential to detect early CAV. The diagnostic accuracy for early CAV is superior than angiography, with very good correlation with IVUS detecting CAV. And furthermore, you can measure myocardial blood flow with CAV, with cardiac PET, where myocardial flow reserve of less than 2 or stress myocardial blood flow less than 2 has been shown to be correlative with poor outcomes. There's an algorithm that was recently published that can potentially be useful to determine which patients would benefit with coronary angiography and IVUS at early stages, and that is shown here with some of the parameters of PET kind of teasing out and allowing differential, where if CAV is highly likely, perhaps coronary angiography and IVUS is in order to determine if interventions can be entertained. So management and prevention currently is focusing, as mentioned, on the balance between immunologic and non-immunologic factors, such as minimizing rejection risk or decreasing inflammatory or injury burden by management of comorbidities, including hyperlipidemia, hypertension, and diabetes. So I know this is a busy slide, but the way that we prevent rejection currently is on maintenance immunosuppression that blocks T cell activation through various pathways. And our conventional immunosuppression is tacrolimus, and in the former period, cyclosporin, as well as MMF and imuran. Prednisone works on suppressing the antigen presenting cells. So cyclosporin and tacrolimus work on the calcineurin pathway, and antimetabolites such as mycophenolate and imuran work on suppressing cell cycle. mTOR inhibitors, such as sirolimus and everolimus, have been present in clinical use since early 2000, and they block T cell activation by blocking co-stimulatory signal of the T cells and also inhibit NF-kappa B. They also suppress cell cycle in the G1S phase. So is there a possibility in preventing rejection and affecting CAV? So recently, Mayo Clinic published a long-term study to address this and looked at whether sirolimus can affect CAV progression over time. And this is the longest follow-up study to date on the effect of mTOR in CAV development, which spanned over 20 years. So 402 heart transplant patients from 1994 to 2015 were either converted to sirolimus early, as defined by less than 2 years, or late, greater than 2 years, and compared with standard maintenance immunosuppression comprised of calcineurin inhibitors and then MMF or azathioprine and prednisone. Over half of them in this group was on cyclosporin rather than tacrolimus. The median time of early converters were 1.5 years, and later converters were just slightly over 4 years. And compared to the calcineurin group, the sirolimus converters had significantly decreased rate of progression of CAV, as shown here. In addition, sirolimus conversions significantly reduced CAV-related death, as shown here. And this stood over a period of 20 years. There was a higher rate of rejection in the sirolimus group, but in this study it was not significant, and there was no difference in the incidence of antibody-mediated rejection. So the timing of mTOR conversion is important in impacting the long-term survival, as shown here in this study. So that earlier conversion cohorts had significantly improved outcomes compared to the later converters or patients who were maintained on calcineurin inhibitors. The authors report that sirolimus converters had a median survival of 18 years versus the conventional 13 years that we see based on the registry. The same group showed no benefit after converting after 6 years if one decides to switch at a later time. In fact, it might do harm. In another study which showed the impact of CAV progression was using everolimus, where it was initiated at 72 hours after transplant and was compared with the conventional immunosuppression cyclosporin and azathioprine in this study. And they performed IVUS at 6 weeks and 12 months. And as shown here, there was a dramatic reduction in intimal thickness with everolimus compared to the immune cyclosporin group. The 3 milligram group stopped early in this study due to high risk of mortality and from infection and graft dysfunction. And also of importance is that mTOR inhibitors tend to significantly lower CMV infections, but do risk bacterial and fungal infections if started early. And there was no significant rates of wound dehiscence noted with everolimus that we see with sirolimus. Although imuran was used which is not as effective as MMF. The study and others, this study and other studies using mTOR is fairly convincing that it can slow down CAV progression. So based on these studies, there's definitely benefit in mTOR inhibitors. But what's the downside of this? So currently, the ISHLT registry shows that only 20% mTOR use occurs in the first year, but most programs still stay on TAC and MMF regimen. And a lot of the reasons for not fully converting to mTOR really has to do with side effects and some other issues. So comparing to calcineurin regimen, there is high risk of rejection for mTOR, as I mentioned, particularly noted on monotherapy, which has been used to preserve renal function. So mTOR inhibitors will need to be combined with other agents to prevent rejections. Most programs also have not started sirolimus early, especially because of the higher risk of mediastinitis secondary to wound adhesions. Also, there's pericardial and pleural effusions that were noted in the earliest studies. So as a result, they avoid the initiation of sirolimus at least 4 to 6 months into transplant. Most patients note significant change in edema. I have many patients who claim that they have felt more bloated and have developed some diuretic resistance due to mTOR. And there's also some side effects, GI side effects being nausea and fatigue is also common. In addition, mTOR can also cause significant renal dysfunction, especially in combination with calcineurin inhibitors and risk for proteinuria. And everolimus is also very expensive. It's not really covered in most of our insurance. So what about other intervention strategies? So a multi-center study was conducted to look at the role of B-cell suppression on CAV development due to antibodies causing AMR, and B cells are the cells that form antibodies. So a preclinical study in monkeys showed positive outcome with CAV prevention with rituximab induction. So this study looked at this question by using rituximab as induction therapy at day 0 and day 12. And it was an IVUS study which was performed at 4 to 8 weeks and at 12 months. And the primary endpoints were plaque atheroma measurements, as well as secondary endpoint was death, retransplant, and CAV development. And the patients were not sensitized in this study. And surprisingly, as you see here, there was more progression of CAV with rituximab. The rejection rates were similar, as well as presence of donor-specific antibody formation. But based on this study, it appears that early B-cell suppression is not ideal. Interestingly, in this study, there was a higher level of class 2 antibodies with the rituximab group, but had lower class 1 antibodies in the sample. So what are the other management strategies that we can consider to try to suppress and prevent accelerated CAV? So one of the landmark papers is the use of statin in CAV prevention. And early statin use appears to decrease intimal thickness. So in this study, Pravachol was started immediately after transplant, and with IVUS, they looked at changes over a course of a year. There was a lot less rejection also noted in this cohort. And based on this study, as you can see here, initiation of Pravachol significantly blunted the progression of intimal thickness in 1 year. Furthermore, blood pressure lowering decreases CAV progression and improves blood flow. So in the Cleveland Clinic, 82 transplant patients in the study underwent IVUS study, and they determined the combination of ACE and calcium channel blockers to have more impact on CAV progression. And in another recent study, Ramapil appears to be beneficial in coronary blood flow. They did not see blunting of the intimal thickness, however, but they also showed that it was safe to initiate ACE inhibitors early, regardless of renal function. So other prevention strategies include prevention of CMV with ganciclovir, as well as addition of aspirin. So for the last couple minutes, I would like to introduce a commercially available product that I think can provide some mechanistic clues on graft injury and inflammation that may help design new questions in study CAV. So this is a busy slide, but this is just a website of the commercially available product. But the molecular microscope diagnostic is a kit that is available to process biopsy specimens for RNA expression using gene chip microarrays to determine increased expression with injury. And based on the expression level, probability of whether there's rejection and the various type of rejection can be determined, including whether the graft has an injury pattern. This methodology is useful since there's variability in interpreting biopsy by pathologists, and then also can overcome sampling error from biopsy not capturing true rejection. And as mentioned, identification of antibody-mediated rejection is crucial to try to suppress and prevent CAV progression. This method can also demonstrate whether AMR occurs with de novo DSAs when patients are clinically silent and are C4D negative. This is a busy slide, but this company are able to report and display the probability of rejection using machine learning algorithms. And they've developed cluster analyses to give us probability of where the biopsies fall into, whether they're antibody-mediated rejection, normal, etc. Also, gene transcript data is provided so we can see exactly in our patients what genes are increased, which can potentially allow us to think a little bit more about our patients and try to figure out preventive strategies. I can see various uses of this in clinical practice, and I think it can also help tailor immunosuppression to try to shut off inflammation, especially in biopsy specimens that show PMR H+ or I+ without clinical evidence of rejection or DSA positivity. So I'd like to go back to the case. So the first case was the 38-year-old with severe CAV at the first year. And, she did indeed develop early AMR, likely contributed by massive inflammatory burden. Her highly sensitized preformed antibodies caused her to be at risk for AMR. And she did develop all two types of rejection and also recurrent AMR. She had aggressive management to treat her AMR, including plasmapheresis, IVIG, rituximab, Velcade. I also treated her with tocilizumab, which is an IL-6 antagonist to try to further suppress T-cell activation. She was switched to sirolimus TAC early at 8 months to try to suppress CAV, but unfortunately, it didn't slow down the progression. And she was not a retransplant candidate due to elevated antibodies with calculated panel-reactive antibodies of 97%, which means that even with retransplant, we will be dealing with the same thing. Unfortunately, she died of sudden death. The second case is different in that the patient did not have sensitization going into transplant. He did not have rejection so far. And the only risk factor that might be contributing right now, non-immunologically, would be diabetes, his obesity, and hypertension. So he was switched to tacrolimus in the first year. I've kept his diabetes under good control. We're working on his BMI to reduce weight. He is on double agent of losartan and lodipine to try to prevent CAV. And then he's on Pravachol 40 to lower the LDL less than 100. But he does have triglycerides, which is a reflection of probably an inflammatory burden from metabolic syndrome. I plan on adding Zadia. So in conclusion, CAV continues to affect graft outcomes after transplantation, despite advancement and maintenance immunosuppression. So therefore, the best method is really to buy time to slow down the development and progression of CAV. Endothelial dysfunction and injury contributes to the development and rapid progression of CAV. So we could try to minimize that risk is crucial to the development and acceleration of CAV. Early recognition of CAV is crucial for fine-tuning management and also defining prognosis. I hope I convinced you that angiography is not sensitive enough to diagnose early CAV, and that adding IVUS data is important to really appreciate early CAV and improve how we think about CAV progression. mTOR inhibitors clearly show that it impacts and slows down the progression of CAV, but unfortunately, early initiation is limited by the wound healing that I discussed, as well as the side effects leading to at least 30% of our patients having to go back to conventional treatment. Non-immunologic contributors are important to try to suppress CAV in a non-antibody way. And then there's not much progress that has been made in the intervention of CAV over the past 25, 30 years. And I'm hopeful that newer technologies such as the molecular MMDX profile and can generate proteomics and genetic methods, as well as advancement in imaging to improve our diagnosis and impact on CAV development. So what are the next steps? I think it's important to add IVUS data to our transplant cohorts, especially in the first 3 years, to define their trajectory. IVUS can be important, especially it'll be interesting to see what the impact of Hep C donors have on CAV development. We definitely need more understanding of what is the ideal immunosuppression level and cocktail for patients. I'm hoping that we can consider pharmacogenetics to try to figure this out by designing studies in the future. We really do need more work on donor management issues. There has not been much change on this area. And it will be interesting, such as using the MMDX to look at ischemia perfusion injury to see how they differentially impact changes in our patients that might show how CAV progression differ between patients. And I have not had time to talk about this, but palliative care issues in patients with advanced CAV is essential. I really don't have a good sense of discussing death and dying in patients with advanced CAV and graft dysfunction, but perhaps it's really time to consider that, especially with limited changes that we have in impacting the disease and progression. Thank you for your time and attention.